Welcome to ATCM, the Emergency Medicine Channel. Today we'll be discussing a case of an elderly man who presented to our ER with alleged history of deliberate self-harm. Can we begin, sir?
Yes.
So this is 61-year-old male patient who came into the ER in an ambulatory state. He walked in with an alleged history of deliberate self-harm. Apparently, he is an advertising supervisor by occupation who used a brand name Ecalux pesticide for his gardening purpose.
Okay.
So Ecalux composes of quinalphos, which is an organophosphate compound. So in a fit of rage while over an argument with his wife, he happened to consume an unknown quantity of organophosphate, this compound. But according to the patient, he said about 50 to 100 ml. And within about 15 to 20 minutes of his ingestion, he came to the hospital.
What is the importance of knowing the quantity of a poison, like this OP poison, in a patient who is admitting under you?
We get to know in two things. So one is how much of he is consumed, then the solubility, and then the toxicity severity we can get to know. And then second thing, potency of the product. If it is very potent, then even minimal quantity itself will cause a lot of side effects, complications.
Okay.
So this patient had an unknown ingestion, but he said about 50 to 100 ml. And following his ingestion, the wife tried to have like a forced emesis by feeding the husband with concentrated salt water, but he did not vomit. There was uneventful time in the 15-20 minutes of post ingestion, and he was brought to the ER. So within 5 minutes of his arrival, we did a gastric decontamination. After we
What do you mean by decontamination in a poison case like OP? That is not only gastric. What is decontamination?
So basically, when a patient comes in, it is for both the patient and the health personnel. We have to wear a personal protective equipment along with gloves, and then we take the patient to an isolated area. Then we expose the whole body and then save the material clothes, and then after that we give a thorough wash.
Kept like saved for
Samples.
future police reference or something like that.
And then we give a thorough wash with water, soap water. We clear all the skin, hands, face, all of that, because even OP has a skin absorption. So if we don't wear gloves and if we were to get exposed to touch the patient, then even we will get exposed to organophosphate compound. So once we give a thorough wash with soap and water, and then we make the patient lie down, and then if the patient presents within 1 hour, then there is role for gastric decontamination.
Okay. Gastric decontamination, if a patient comes less than 1 hour, it is very effective. More than 1 hour, it is not that effective, but even then large quantity, if the patient has taken large quantity, it takes some time to get removed from the stomach. So even after 1 hour, we can try if the quantity is very large, or if the patient has taken with some reduced drugs which can produce reduced mortality. Both are possible. Some patients may take extended release tablets. They may be removed very slowly. In that condition also, we can give gastric decontamination after 1 hour. But normally, many hospitals we use Ryle's tube for gastric decontamination. That is not correct way of doing decontamination. There is a different tube for that has to be done. Okay. But since the need of gastric decontamination according to standard guidelines are coming down, many hospitals don't follow that that rule, using the larger bore
Tube.
Okay.
So this patient, we gave an activated charcoal, 1 gram per kg. So about 60 grams was given, and while we were proceeding with the gastric decontamination, he happened to have seizures.
Okay.
It was a GTCS seizures lasting for about 2 minutes, and it self-terminated. And then he had decreased sensorium following seizure episode with decreased respiratory effort. So because of which we intubated the patient using an endotracheal tube of size 8. And now the side effects
Has the patient taken any alcohol along with
No, sir. No co-ingestions. He generally does not consume alcohol, and he doesn't even smoke. So it was just entirely only that pesticide. So then we intubated the patient. Basically, the component side effects of OP is sludge, excessive salivation, lacrimation, urinary incontinence, defecation, gastric secretions, and all. Basically, all the secretions
Secretions will
increases.
increase.
So in this patient, the
That
reason
most important part of that secretion is what? For a ER physician. Most
aspiration,
Lethal.
Le-
Lethal part of that secretion.
is aspiration. He can choke on his own secretions,
Secretions in lungs,
lungs,
bronchoria.
bronchoria. Mm.
That is most important for a ER physician or critical care person, because we are mainly targeting that in controlling the problems in OP poisoning. Other things are there that also has to be treated. Okay.
So in this patient, the reason why we early intubation is mandated in case of OP poisoning is because of bronchoria. So patient can choke on his own saliva, on his own secretions. So whenever there is patient with decreased sensorium or respiratory involvement, we intubate the patient. So this patient was intubated, and following this, we gave him rapid repeated doses of atropine. So atropinization goes in with every 5 minutes. We have to keep giving bolus doses and double the dose.
Can you tell atropinization in a normal person and a person who has taken OP? That both are different.
Okay. So for an OP patient, we give atropine every 5 minutes. We keep doubling the doses
That I
until the
understood.
patient.
What is atropinization? In a normal person, I am giving to you atropine. Maybe due to surgery or something, you may get atropinization. But another person who is having OP poisoning, for him I am giving atropine to counter the action of OP.
OP.
What is the main difference?
Rapid.
For a normal person, when we are giving atropine, we are only seeing the heart rate. We are targeting the heart rate. Heart rate should not go to a severe range of tachycardia. That is only in our mind. And if you give more dose, he will become like agitated, anxiety, all these things. Whereas in OP poison, our target is entirely different. It is not heart rate, it is not the agitation. What is the target?
Bronchoria.
Drying up of the secretions, whether it is bronchoria, saliva, urination, whatever it is. But there the target is different. Whereas in a normal person, when we are giving atropine, like bradycardia, you are giving atropine, just increase the heart rate. But here you should never go with the heart rate. Heart rate can increase or decrease. That is not our primary aim. Primary aim is to reduce the secretion in the lungs. When you are auscultating, you will not get crepitation. When the patient is on ventilator, his tidal volume achievement will be normal. That you have to be very careful.
So we intubated the patient and gave atropine. So in atropine, we give every 5 minutes. We keep doubling the dose, so it will go up to hundreds of mg. It is not about the quantity of atropine we give. It is symptomatic management for atropine. And once the lungs have dried up and secretions have stopped, then 20% of the whole cumulative dose we start as infusion. So this is how atropine is given.
Atropine can be given either as bolus doses or infusion. Both are equally effective. Why they are equally effective? Because here we are not targeting the heart rate. We are not at all targeting the heart rate. Heart rate, so you can see when you are in cardiac arrest in bradycardia, you give atropine. What is the normal half-life of a single dose of atropine?
20 minutes.
Act only for 3 minutes. You can see you are giving atropine 3 minutes, it will remain active in the cardiac this one. But the pupillary dilatation, urinary retention, all will be long standing. But the heart rate response will be only for 3 minutes. That's why we are giving repeated doses. Okay, so atropine, in that sense, it is a short acting drug. So when you are giving either infusion or you are giving bolus doses, in heart rate, this one there is no difference. But in secretions, whatever way you give, whether bolus or this one, secretion has to dry up. Okay, so both are equally effective. So here, since we are not targeting the heart rate, both are equally effective. So depending on your convenience, you can give either repeated bolus doses, like 5 minutes you can give, 10 minutes you can give, every 15 minutes you can give one bolus, or you can give continuous infusion of atropine. Continuous infusion atropine, one advantage is if you set for that, there is no problem. Otherwise, sometimes the staff may forget to give 1 or 2 doses of atropine, then it will create problem. Continuous infusion means without any failure, patient will receive the dose. Okay. And both are equally effective.
So apart from atropinization, the other thing that we have to see is pralidoxim, oxims basically. But if it is an
Now, atropine, one more
organophosphorus.
problem is this patient is already agitated. So if this patient is ventilated, you are knocked out the patient. There is no issue. Suppose the patient is agitated in ICU, you are giving atropine, but still lungs are not dried up. What will you do?
We continue giving atropine, but at the same time we give a sedative like antis.
So either you add glycopyrrolate to the atropine. You reduce the dose of atropine and add glycopyrrolate. Advantage of glycopyrrolate?
It doesn't have
It will never cross to the
blood-brain
barrier. So the overdose will not produce any agitation. But some patients require neurological control of OP. So because if you see the effects of OP, one of the effect is central action. Okay. So in that type of cases, you have to definitely give atropine. So you reduce the dose of atropine, but add glycopyrrolate. Glycopyrrolate act peripherally, and atropine, whatever atropine you are giving, that crosses the blood-brain barrier and act there. But the over-atropinization signs like agitation will not be there. So if the patient is agitated, you can reduce the dose of atropine and add glycopyrrolate. If you want to control the problem in the CNS problem due to OP poisoning, then you have to mix both atropine and glycopyrrolate. Okay.
So apart from this, oxims has something called as an aging process. So we have to only give it an organophosphorus poisoning. It's not very effective in carbamate poison. Aging is basically the neuroreceptors. The receptors, they get saturated. So pralidoxim, if you give it, won't be effective because all the receptors get used up.
Depends on the time. More time, if the OP is staying with the receptors,
it's ineffective.
It will become irreversible. That is aging. Okay, whereas in other one, what is that other one? Carbamates. They will not be permanently attached to the receptors. They will be temporary, but this will become permanent after some times. So if you are giving oxims early, then that will be effective. Late in OP poisoning, if you are giving these carbamates, pralidoxim will be ineffective.
So apart from this fluid,
so immediately you have to start.
Immediately we started, and that is given a 20 to 30 milligram per kg dose. Okay. So then 30 milligram per kg, and then along with that atropine and fluid resuscitation also has to be given simultaneously. So in our initial 10 seconds.
Why fluid?
That is, patient can develop hypotension to clear off the...
If the patient develops hypotension, you have to give
fluids.
But here, what is the main problem? In OP poisoning, in lungs, what is the main problem? What is the pathology in lungs?
Increased secretions will be there, bronchurias.
It's a type of ARDS. What is the main strategy in ARDS in ventilation?
PEEP.
That is, sorry, in ventilated ARDS patient, what is the strategy of fluids?
We don't give
liberal or restrictive. The two school of thoughts. One is liberal fluid, give a large amount of fluid. Another one is
restrictive. We maintain a negative balance.
So normally we try to maintain negative balance. That is because already lungs are full of water. You try to remove some amount of water from your body. The fluid in the lungs may shift to the intravascular compartment. That's why newer guidelines say that restrictive fluid strategy is better than liberal. Liberal means large amount of fluid what we give in sepsis. That may create sometimes problem. So better not to give too much fluid. We try to control the BP with some other means.
So then in our initial reassessment, patient was now intubated. So airway was secured. Breathing wise, patient was tachypneic with a respiratory rate of 22, but we had taken control with the ventilator. So we had set the ventilator respiratory rate about 20, and then circulation, but bilaterally auscultation wise, he had crepitations and wheeze. Predominantly it was wheeze, but basal areas there were profound crepitations heard. Okay. Circulation wise, he had a heart rate of 67 beats per minute with a blood pressure of 140/90, and all peripheral pulses were palpable. Then disability wise, he was even VT-M1 following ventilation, and then pupils were constricted and very sluggish reactive to light. So about 1.5 millimeters symmetrically bilateral, but sluggish reaction. Exposure wise, there was no other signs of injuries on the patient's body, no discoloration of skin, hair, nails, and teeth. And patient had a normal body temperature with the GRBS of 145 milligram per deciliter. So with this reassessment, we moved to the secondary
Do you
sample.
think that in this patient normal body temperature will be always there?
No, patient can have hyperthermia.
Because we are giving atropine. Many patients can have a high temperature. Okay.
So then, in our ABG wise, patient initial ABG itself had a PCO2 buildup with a pH of 7.32 and a bicarbonate of 64. Or not bicarbonate, PCO2 of 64, bicarbonate was 26.
Okay.
Lactate levels were normal. Electrolytes wise, he had hypokalemia, but otherwise, rest of the electrolytes were normal. In our sample history, as I stated, so patient in a fit of anger took that, and within 20 minutes he was brought to the ER. He is a known case of CAD. He underwent stenting, PTC, about 6 months back. He was on dual antiplatelets with atorvastatin and nitroglycerin. Those were his regular medications. Drug allergy as such he didn't have. So lab investigation wise, he had mildly elevated
Suppose
CRP.
this patient develops tachycardia because of atropine. Suppose. Tachycardia is not a good thing in a patient who is having CAD. How do you manage that?
But beta blocker can't give bronchospasm. We can give ivabradine, sir, for
Give whatever
tachycardia.
drug, beta blocker, ivabradine, diltiazem, whatever you can give, you have to give. Because here we are not, many doctors think that we have to keep the heart rate high. Because bradycardia is one of the problem of OP poisoning. Tachycardia can be induced by atropine. But the problem in a CAD is we don't want tachycardia. So you have to control the heart rate. Controlling heart rate in OP poisoning will not be like harmful to the patient. So you have to control the heart rate, whether it is OP induced or something else. Heart rate, when it is increasing, you have to control it. Okay.
So OP has an effect
So
on
OP
the heart.
can OP produce tachycardia? OP
Yes, if
poisoning
it is activates the nicotinic receptors,
If
it will
nicot-
cause tachycardia.
What is the percentage of tachycardia in OP poisoning? So 20% of the patients will have tachycardia in OP poison. So basically, some patients can have tachycardia, and the drugs we are giving that also can produce tachycardia. So tachycardia is not very good thing in a patient who is having coronary artery disease. So it is better to control with some drugs the heart rate, whether it is beta blocker, ivabradine, or diltiazem. Beta blockers will not produce bronchospasm in all patients. Those are prone to develop bronchospasm. In them, it produces bronchospasm, not in all patients.
Then we have to take an ECG, and ECG we'll have to look for any heart blocks, bradycardia, any arrhythmias, QTC prolongation. All of these will be the features of cardiotoxicity in case of an OP poison. In this patient, he had a sinus rhythm with a heart rate of 67 beats per minute, but QTC was prolonged. It was 538.
Okay.
So high chance for patient having arrhythmia, and in these cases, if we give ondansetron, again it will further cause QTC prolongation. So it has to be avoided. Then this patient had seizures, but there is no role of anti-epileptic drugs. Like we don't really have to start the patient on levetiracetam or anything of that sort. And then so mainstay of treatment is only atropine, and then supportive management. If at all patient comes within 24 to 48 hours, then pralidoxin we can give. And other than that, fluid resuscitation, and then DVT prophylaxis, nutrition, all of that.
Okay.
Then we have to send the blood for toxicology, and also RBC pseudocholinesterase activity also can be checked. When we have to extubate the patient when the patient has dried up lungs plus full GCS and is also able to tolerate the spontaneous breath trial.
Okay.
Then we can extubate the patient, but there is something called as an intermediate syndrome,
Okay.
which happens like 1 to 4 days post ingestion,
Okay.
which is a neurological disorder where patient goes into acute paralysis
Okay.
because of the
What are the
receptors.
problems of this acute paralysis?
One
Intermediate syndrome, there are many theories behind that. One of the theory is release of toxins from the fat depot. But there are other types of theories also there. But whatever it is, patient can large amount of poison if they consume, they can develop intermediate. This patient had developed has taken large quantity of
quantity.
poison, so they definitely develop all these problems.
So 10 to 40% go into intermediate syndrome. So in that also the treatment is again atropine.
Okay, so what are the clinical findings of
One patient will have neck flexion weakness, decreased deep tendon reflexes, respiratory insufficiency.
That is the most important thing. For a ER doctor. Neck flexion, neck holding power is not there, nothing, there is no issue. But if the patient develops tachypnea after 2-3 days, then you have to think about there is a
Intermediate
possibility of intermediate syndrome. And again, foot drop, everything can come. Foot drop, neck flexible, neck inability to extend the neck. That is most important. So all these things are important. But if the patient develops tachypnea, you have to think about
Intermediate
syndrome.
So then
Atropine is the treatment.
atropine is the treatment of
Not
choice.
PAM.
So then this patient, after you put him on ventilator.
What is the age of the patient?
61 years old, sir.
We catheterize the patient immediately.
We catheterized much later.
Before starting
Atropine. That is
Urinary
very important.
retention.
That is, before starting atropine, you have to catheterize the patient. After atropine, it will be very difficult to catheterize the patient. Okay.
So this
We
patient,
start trials to feed for this patient.
we didn't start for the 24 hours, we didn't start, sir, after 48 hours, because gastric
Gastroparesis is very, very common with large dose of
OP.
OP. So we have to be very careful. So don't feed for at least for first 24 hours.
4 hours. So then after this, his 48 hours was uneventful. So he was shifted to medical ICU for further care. Now OP has much of morbidity rather than mortality. Now there is something else also called as organophosphate induced delayed neuropathy.
Okay.
So in that also the patient can end up with neurological disorders
What
like
will be
weakness,
the,
paresthesia.
What will be the sign of that?
Stocking glove paresthesia.
Okay, distal polyneuropathy, like a patient can have glove and stocking type of sensory neuropathy. Many patients can have persistent foot drop. So in ICU, we have to always check for foot drop. Okay, any patient who is admitted in ICU, OP poison, you have to check for foot drop. Okay.
So along with this,
If the patient develops foot drop, what do you do?
that splinting.
Splinting is very important, because if you don't do splinting, then ultimately patient will have continuously dropping foot, and that produces a lot of injuries when they walk. Okay.
So apart from this, DVT prophylaxis has to be taken into consideration, since the patient will have a prolonged ICU stay, and prolonged mechanical ventilation is mandated if the patient has consumed large quantities of OP, and patient develops respiratory insufficiency. But early intubation, atropinization is the mainstay of management for OP.
Okay.
So
we give antibiotic?
Antibiotic only if he's aspirated the thing.
Normally antibiotics are not required, but many patients in ICU, they develop ICU-induced infection, ventilator-associated infection. To prevent that, you can, depending on your internal flora, you can put some antibiotic. Otherwise, there is no requirement of antibiotic.
That's it, sir.
Okay. Thank you.
Thank you, sir.